Welcome to our March webinar hosted by the Celiac Research Center at Harvard Medical School and the National Celiac Association. I'm Lee Graham, Executive Director of the National Celiac Association, founded in 1993. The launch of NCA's Feeding Gluten-Free initiative in April in response to the need at food pantries has exceeded our expectations. Up to now, we have shipped $450,000 worth of gluten-free food to food pantries in 29 states. But even so, the need continues. Food pantries tell us that the demand is 2 to 3 times more for gluten-free families than ever before. And we've heard stories about moms and dads skipping meals so their celiac kids can eat gluten-free. I hope you can help us help these needy families by donating on our website to nationalceliac.org. We really appreciate it. Thank you. For today, you are welcome to ask general questions through the Q&A feature, which is located on the bottom right corner of your screen. If you're still struggling to connect with us, tech support is available if needed at digitalmedia@partners.org or by phone 857-282-6470. Also, this session is being recorded and will be available for viewing on NCA's website, nationalceliac.org. I'm excited to introduce today's moderator, Dr. Dasha Weir. Dr. Weir first became interested in celiac disease during her medical training and is now a board-certified pediatric gastroenterologist with expertise in celiac disease in children. She is the Associate Director of the Celiac Disease Program at Boston Children's Hospital and serves as the medical advisor of the hospital support group, Celiac Kids Connection. Originally a Boston area native, she attended Dartmouth College and graduated with a BA in history in 1995. She subsequently graduated from Case Western School of Medicine in 2000. She returned to Boston and completed her internship and residency at pediatrics at Boston Children's Hospital and Boston Medical Center. After finishing her pediatric gastroenterology fellowship at Boston Children's Hospital, she joined the Division of Gastroenterology and Nutrition there and is involved both in clinical care and celiac-related research. She is also on the executive committee of the Harvard Medical School Celiac Research Center. Let's welcome Dr. Weir.
Thank you so much, Lee, and thanks to the NCA, not just for all the wonderful work you do, but also for this excellent webinar series. I'm really pleased to be involved in today's session. And the topic today, as you all know, is Get the Facts on COVID-19 Vaccines and Celiac Disease. We have 2 speakers today, and it's my pleasure to introduce our first speaker, Dr. Ofer Levy. He is currently a professor at Harvard Medical School, as well as principal investigator, staff physician, and director of the Precision Vaccine Program in the Division of Infectious Diseases, Boston Children's Hospital. The Precision Vaccines Program is a platform to foster international collaboration between academia, government, and industry for development of vaccine formulations optimized to protect vulnerable populations. He currently leads several NIH-sponsored studies, as well as a number of coronavirus and COVID-related studies, including a national effort to discover biomarkers of COVID disease severity and a project to discover and develop novel corona vaccines. So with that, Dr. Levy, thank you so much for joining us. We know you're very busy, and go ahead and share your slides and get started.
Thank you for that, Dr. Weir. A pleasure and an honor to be invited to speak in this forum. So the title of my talk today is Coronavirus Vaccines, Light at the End of the Pandemic Tunnel. My name is Ofer Levy. I'm a physician scientist and a staff physician in infectious diseases at Boston Children's Hospital and director of the Precision Vaccines Program, where I direct a multidisciplinary team of individuals building networks of collaboration across academia, government, and industry to develop next generation vaccines to protect highly vulnerable populations. The topic of our talk today is the Severe Acute Respiratory Syndrome Coronavirus 2, or SARS-CoV-2, and by now, the audience is well familiar with the appearance of the virus as a ball with these protrusions or spikes, the spike protein, antibodies against which may protect the human body against infection with this virus. As of today, the 25th of March, 2021, we have had more than 30 million reported cases of SARS-CoV-2 infection in these United States. And I'm sorry to report over 545,000 deaths of our fellow Americans. Now, thankfully, the number of cases is now flattened, as you see here in the slide from the New York Times, and the death rate has been coming down, as has the hospitalization rate. That's good and welcome news, but we're not out of the woods quite yet. A little bit about vaccine development, because yes, the social distancing measures are critical, the hand washing, the masking, the social distancing, and we will have to continue that for the foreseeable future. And a key game changer is the introduction of vaccines. And a little bit about a word about what's involved in vaccine discovery and development. This figure is from a review article from my colleague Rino Rapulli, who was with Novartis vaccines. And this summarizes the investment in R&D across time as one discovers and develops and commercializes vaccines. And what you see is, as expensive as the basic research we do is in the discovery phase, it's but a small fraction of what it takes to get vaccines all the way into late development and either authorization or approval. And so this valley of death between the early development, late development, where a lot of medical products don't even make it to full trials because of the costs involved. And that's important to bear in mind. As of a day or two ago, I think the numbers are still similar. There are still 45 vaccines in phase 1 clinical trials, coronavirus vaccines, 32 in phase 2, 23 in phase 3, already 6 authorized and 7 approved. This is historic. Across human history, vaccines would on average take 10 to 20 years from conception to an approval and use. To do it in 7 to 9 months is unheard of and is a testament to human ingenuity and to the resources that were pumped into this effort. Vaccine testing process involves approval, where regulators in each country review the trial results and decide whether to approve a vaccine or not. This is from the New York Times. You're familiar with the Operation Warp Speed, which began under President Trump. And without taking any political stances here, I do think it's fair to say that the resources invested in Warp Speed did make a difference here in the rapidity with which serious vaccine candidates emerged, and some now even authorized and in use. Now, when this whole discovery effort started, I put together this slide, which just reflects my personal opinion at the time of what would be the characteristics of a successful coronavirus vaccine. Looking at safety, efficacy, durability, scalability, and cost. Before we had any vaccines, we'd say, well, at minimum, vaccines you give to healthy people, so they've got to be safe. So we'd want to see no severe adverse events associated with a vaccine. You'd want it to be at least 50% effective. In other words, if you get the vaccine, at least your risk of getting COVID goes down 50% at least, you'd hope. You'd hope to be protected for at least 6 months. We don't know the durability at this point. And you got to be able to make at least millions of doses. And the cost, hundreds of dollars a dose is very expensive, but there are vaccines that cost that much. So that would be the minimal requirement. Moderate would be a few modest adverse events, but nothing beyond that. 70% efficacy, durability of a couple of years, scale to tens to hundreds of millions of doses, and a cost of $1 to $10 a shot. Optimally, you'd have a vaccine that's perfect. There is absolutely no adverse events, not even a sore arm, not even a fever. There is no such vaccine right now, and it's 100% effective in everyone. In a perfect world, a single shot would give you lifelong protection. You can make billions of doses very cheaply for less than $1. We're not there yet, but that would be the perfect solution. Now, many factors impact vaccine responses. It turns out that men and women have distinct immune systems. Age is a factor in immune responses. A response in a middle-aged individual does not necessarily equate or predict a response in an older individual or a young child, an infant. Seasonality could affect immune responses. Giving a vaccine alone or together with other vaccines, giving different types of vaccines result in different immune responses, and giving the same formulation in one part of the globe or another can lead to different responses due to genetic and epigenetic differences between populations, the diet, what we eat, and other environmental factors. Driven in part by these considerations of applying precision medicine principles to vaccine development, Boston Children's Hospital in 2015 created the Precision Vaccines Program under my direction. It sits within the Division of Infectious Diseases. We're largely funded by the National Institutes of Health, specifically National Institute Allergy and Infectious Disease, NIAID, Tony Fauci's organization. And really, we are a platform to enhance collaboration between academia, government, and industry to develop vaccines for vulnerable populations. We have a precision vaccines network of over 400 individuals around the globe from academia, government, consultants, and industry who collaborate across a range of projects. Our resources are quite varied. We have administrative, technical, bioinformatic, organizational, legal, and graphic capabilities. We have a website. We have a program coordinator and a Twitter account. For those of you who do Twitter, we're at PREC Vaccine, at PRECVACCINES, if you want to follow us on Twitter. Now, how do we develop precision vaccines? We use a variety of tools. We piggyback on targeted clinical trials of different populations. We obtain small volumes of blood before and after immunization, and we use systems biology. These are powerful tools that allow us to measure the entire inventory of all the cells, all the molecules in a sample before and after a vaccine. Big data. How does your body cells and molecules, how do they change after a vaccine? And how does that correlate with something we care about clinically, like protection against infection? And how do we use that information, model it outside the body by creating in vitro systems, tissue culture systems, where the human immune system can be modeled in an age-specific way, a newborn, a middle-aged individual, an elderly immune system outside the body, getting blood donations from volunteers and using that blood, using those white blood cells outside the body in tissue culture to model vaccine responses. Because in these in vitro tissue culture systems, the same individual in these different wells of a plate can be both the control condition and the treatment condition. That's something we can never do. If everybody on this Zoom conference right now was in a clinical trial, each of us would be assigned to a treatment group or placebo group. But in the in vitro system, we can test the same individual at the same time across multiple conditions. You could be the placebo and different doses of the treatment. And we can model that and learn about vaccines and benchmark new vaccines against those that are known to be safe and effective, get them right from the pharmacy, currently used vaccines, and model the responses. And therefore, we can benchmark and learn what are the markers, the biomarkers of safe and effective vaccines, and use those lessons to discover new molecules that boost immune responses called adjuvants, and build even better vaccines, trying to get single dose protection, and test those vaccines in appropriate animal models and keep this cycle of precision vaccinology going. We are based in Boston, Massachusetts, on Blackfan Street, at the Harvard Institutes of Medicine building around the corner from Boston Children's Hospital. We're on the 8th floor of this building. We're the first Boston Children's Hospital lab to occupy space, that's newly renovated space for the Precision Vaccines program. Now, one approach we've taken during this pandemic to develop a vaccine is to develop a vaccine that would work well in the elderly. As you know, the elderly are particularly susceptible to severe COVID and sadly COVID-induced death. One approach we take for this is using adjuvants. Adjuvants are molecules that boost an immune response. In the top panel, you see the injection of an antigen. An antigen is an antibody generating substance, something that induces antibodies in your body. What happens when you inject just the protein to get as an antigen is you get an antibody response, but it tends to come right back down, and you need multiple doses to get protection. What we're doing is discovering small molecules called adjuvants, from the Latin adjuvar, to help or aid. You add these as booster molecules to the vaccine formulation. You get much more profound white blood cell activation, and optimally, you could get single shot protection with antibody levels that last a long time. And we try to discover adjuvants that work particularly well in the elderly. And in fact, our philosophy of testing molecules outside the body against human cells has now informed the US strategic plan for research on vaccine adjuvants. And you see in the graphic that different vaccine formulations are ultimately envisioned for people of different ages, different sex, etc. And we try to tailor our precision vaccines approaches also in terms of people's attitudes towards vaccines. You could design the best vaccine in the world, but if nobody wants to take it, you're not going anywhere. So we do qualitative research with Elisa Weitzman in our program, who's an expert on qualitative research, and interview people about their attitude about immunization. And that's very important to understand as well. There are different routes of immunization. There are different antigens, like the spike protein of coronavirus we can use, and different adjuvants, the booster molecules we can combine in different proportions. We can test these outside the body, call that in vitro, and target the kind of immune response we want in that population to best protect them. Here's an example of how we did this in the elderly. And I'm very proud of the members, a shout out to the members of the Eitz Chaim Synagogue in Cambridge, Massachusetts, many of whom at the height of the pandemic came into town to donate blood for this project, where we would obtain blood from the elderly and test it outside the body and test different molecules to see which would be best at activating an elderly immune response outside the body, and then use those molecules to advance them into the animal studies. This is a very unusual way to make a vaccine. In other words, start with the human system, make sure your molecules are working well in the target human system outside the body, then advance those into the animal models. And that's, we believe, a much more efficient way to try to get towards single shot protection in the elderly. And that project is ongoing, and we already have a lead formulation for the elderly. In fact, there's a company in India called BioE that's already leveraging the adjuvant combination that we had discovered, and that's already in clinical trials, including in elderly individuals in India. And the idea there is to develop vaccines that don't require deep freezing, because in poor parts of the world, -80 freezers are not very available. Now, another approach, which you've now heard a lot about, and this slide is courtesy of Moderna Therapeutics. I don't receive any funding from Moderna, but full disclosure, are mRNA vaccines, where the mRNA is injected, the mRNA encoding the spike protein, into your muscle and is taken up into the muscle cells, and they express the spike protein of coronavirus, and then your body makes antibodies against that. Now, very important, as we push forward these warp speed vaccines, there was a lot of concern about vaccine safety, which was understandable. The concern is, if we're moving so quickly, how do we know this stuff is safe? And here is a commentary I wrote together with David Knipe and others at Harvard Medical School that was published in the journal Science, ensuring vaccine safety. There have been examples in human history where vaccines have failed due to safety issues. There was a Qatar incident in 1955 where there was incomplete inactivation of polio vaccine, causing polio-like disease in those who received vaccine. In 1976, there was an influenza vaccine under Gerald Ford that was associated with potentially neurologic side effects. In 2007, rotavirus vaccine was associated with intussusception. An intestinal condition was pulled off the market. Dengvaxia in the Philippines in 2017, there was some vaccine-enhanced disease. So there's been lessons learned from all of these unfortunate incidents, and they've been learned by the National Institutes of Health, the Food and Drug Administration, and CDC. And full disclosure, I am a part-time employee of the US government. I serve on the Vaccines and Related Biologic Products Advisory Committee, or VRPAC. I voted on advising FDA on the authorizations for Pfizer and J&J vaccines, and I may also serve in some of the future panels as well. Now, vaccine safety evaluation is considered at every phase of vaccine discovery and development. All the way on the left in our human in vitro systems and in animal studies, we consider biomarkers of safety. Phase 1 studies, just tens of individuals, gather safety data. Phase 2, you're going to hundreds of individuals, larger safety study looking at immunogenicity. Does the vaccine induce an antibody, for example? Phase 3 now, we're talking about tens of thousands of individuals, looking at efficacy and immunogenicity. And then typically the briefing documents come to FDA for review for safety and efficacy. And then if the vaccine is approved or authorized, it is then scaled to millions of people. And that's not the end of the process either. Even after authorization, there is surveillance, active and passive surveillance systems, including opt-in apps called vSafe, where you report symptoms, et cetera. So there are eyes on these vaccines and eyes on vaccine safety during these times of coronavirus vaccines. And all those systems have become electronic and much more efficient, which is good. Now, a word about integrity from Dr. Tony Fauci. Quote, an independent body of people who have no allegiance to anyone, not to the administration, not to me, not to the companies, looked at the data and deemed it to be sound, said Tony Fauci in an interview with Fox News. And having worked inside the process of the FDA, I will tell you I'm very proud of the process we have here in the United States. I think it compares very favorably with the rest of the world. The briefing documents about vaccine safety and efficacy for each vaccine we consider are posted and can be downloaded by any American to review the exact same data I see before I cast my vote. All of our deliberations are public. There's a public commentary phase after open deliberation, and it's all live streamed. We are not allowed to confer secretly about things. We take a public vote. It's an excellent process. What is an emergency use authorization? This enables FDA to strengthen public health protection against chemical, biological, radiation, and nuclear threats, or CBRN. And it's Section 564 of the Federal Food, Drug, and Cosmetic Act to allow for the vaccine's rapid and widespread deployment for administration to millions of individuals. Issuance of an EUA would require determination by FDA that the vaccine's benefits outweigh its risk based on data from at least one well-designed phase 3 clinical trial. Now, here are the authorized SARS-CoV-2 vaccines in the United States. As you've heard, both Pfizer and Moderna mRNA vaccines, both requiring 2 doses. The phase 3 studies were in 30 to 40,000 individuals, efficacy nearly 95%. And then more recently, the Johnson & Johnson single-dose vaccine doesn't require freezing and with an efficacy in the 75 to 80% range against disease, but then even higher efficacy against severe disease and hospitalization. This is just an example of a volunteer receiving Moderna's vaccine earlier this year. And the latest update as of 25th of March, 2021, Pfizer, Moderna, and Johnson & Johnson have all 3 received emergency use authorization, or EUA. AstraZeneca is soon expected to file for an EUA submission to the Food and Drug Administration, and we'll see what happens there. What are the current needs to overcome the pandemic? There's still a lot of work to be done. We need vaccine uptake, shots in arms. We still only have 20, 30%, of high risk and other individuals immunized. We want to get to herd immunity. That might require 70, 80% immunized. So we have a long way to go. We have to, right now, the issue is around vaccine supply, but we're told in the coming month or two, there'll be a lot of supply, maybe even a glut. And then we'll be coming up against vaccine hesitancy. Do the young people take the vaccine at the same high rate that the elderly do? Because young people tend to feel invincible. And of course, there are a lot of different views on vaccines. So we hope to have healthy communication. We have integrity in our process on vaccine safety. We want to have public confidence in these vaccines. They're safe and effective. And we need to take these vaccines so that we protect not just ourselves, but our loved ones and our community. There's also a need for global vaccine supply. A vaccine formulation is needed that's stable at readily achieved temperature. Negative 20, negative 80 degrees isn't going to cut it in rural Africa, Southeast Asia. We need single dose vaccines that are modest in cost. And we have to care about what happens in the rest of the world. It's not just the US. If there are pockets of infection elsewhere, it's a problem. Finally, we have to remember the future. And for those of us of the Jewish faith, we have the Passover holiday coming up, and many of you will recognize the biblical tale of Yocheved bringing baby Moses to the Nile River because the Pharaoh had decreed that the infants will be killed, and she prepared a special basket that was water sealed and put her baby in the Nile in hopes somebody would find him and protect him. And similarly, we have to protect our next generation, our children. And there is currently no authorized vaccine for any age younger than 16 years of age. And in that regard, I recently published with my colleague Stan Plotkin the rationale for pediatric SARS-CoV-2 immunization in the journal Pediatrics, which is the official journal of the American Academy of Pediatrics. And the rationale includes that although uncommon, severe COVID does occur in children. Children do become infected and excrete virus that can infect others. As childhood infection is often asymptomatic, other precautions won't suffice. If strain change decreases long-lasting immunity, children will at least be primed for an accelerated response to infection or revaccination. Vaccination of children will be needed to reach high coverage and potentially herd immunity. This is an important point. Viral mutations are generating variants such as the one in the UK that are spreading more readily to children. pediatric vaccination programs have a high successful international track record in making major advances in reducing infectious diseases. Briefly put, the majority of the global vaccine market is pediatric. The majority of the global infrastructure to deliver vaccines is pediatric. If we're going to get to herd immunity around the globe, a pediatric vaccine is key. There's a well-developed, after immunizing teachers, pediatric vaccination will further accelerate opening of schools and normalizing children's activities, key to their well-being and parental work productivity. And as is the case for other vaccines, mandatory vaccination of children guarantees high coverage as opposed to strictly voluntary vaccination. I have many people within our group to acknowledge. Dr. Al Ozanoff, who's our Associate Director, David Dowling, working on adjuvants, Al Ozanoff on vaccine safety, Simon Van Haren on immunology, and in our leadership group, Asimeni Angelidou, Joan Arce, Dare Odumade, Guzman Sanchez, Kinga Smolin, and Gloria Gasangua, as well as Francesco Borrelio. And our collaborators around the world and our funding from NIH and the Bill and Melinda Gates Foundation and internal support from Boston Children's Hospital. That's my email address, ofer.levy@children's. You could follow us on Twitter at @PrecVaccines, PRECVACCINES, and myself at Levy_O. And if you want to learn more about our program, feel free to contact us. Thank you.
Thank you so much, Dr. Levy. We really appreciate it. We'll be taking questions at the end. I'm pleased to introduce our second speaker. Dr. Lael Yonker is a pediatric pulmonologist and co-founder of the Pediatric COVID-19 Biorepository at Mass General Hospital. She is assistant professor of pediatrics at Harvard Medical School, director of the MGH Cystic Fibrosis Center, and co-director of the MGH Cystic Fibrosis Therapeutic Development Center. Her research focuses on inflammatory responses to airway infections. At the outset of the COVID-19 pandemic, she led the creation of the Pediatric COVID-19 Biorepository at MGH and has helped shape an understanding of how SARS-CoV-2 affects newborns, infants, and children and young adults. Dr. Yonker is currently investigating the impacts of viral load and immune responses in children with SARS-CoV-2 infection or the late COVID-19 related inflammatory illness, multisystem inflammatory syndrome in children, MIS-C, and was the lead author in a recent study in the Journal of Pediatrics on viral load in children that was reported extensively in national and international media outlets. Now, the polling question was yours, and we'll do that now to get started. The polling question that we were hoping you guys could help by answering is, have you or a family member had COVID-19? I've been infected. One or more family members have been infected. Both myself and family members have been infected. And the last is no infection in my household. So we'll give folks a little bit of time to answer this. And then you can go ahead and share your screen.
All right, great. Thank you so much for that introduction. While we're waiting for the responses to come in, I just wanted to thank the NCA for the opportunity to talk about how COVID affects kids as compared to adults, and also thank Dr. Levy for that excellent presentation. That last slide especially really spoke to me because clearly, as you'll see in my slides, I think that addressing addressing COVID in kids is going to really be critical for attacking this pandemic. Let's see. So the results have come back, and so it looks like most people have not been infected or had any household members be infected. 81%. 2% have been infected. 11% have had one or more family members infected. Or 5% have had themselves and family members infected. So knowing that there's a lot of people on the call, that's actually a fair amount of people who've had infection, and so we'll talk about what infection means sort of to the larger community, including kids, and how it compares to adults, and then how to keep ourselves safe. So I'm going to share my screen. As mentioned, so I'm Dr. Yonker. I'm a pediatric pulmonologist here at Mass General Hospital for Children, and I'm director of the Cystic Fibrosis Center here at MGH. And as my role as the Cystic Fibrosis center director, I also do research studying airway inflammation. And so when COVID came around, I had been collecting samples on patients with cystic fibrosis and quickly pivoted and started collecting samples from kids with COVID-19 or coming for, for evaluation for COVID-19. And when it started out, the numbers were quite small, and we were really trying to reach out in every way possible to try to learn from kids. Why are kids handling the infection so well? And things have changed over time, and clearly there's lots to still learn, but I'm going to share with you some of the things that we've learned since we've started now a year ago. So I have no disclosures. And so here we were last year. It's hard to believe it's been a year. And the numbers were very small, and you can see that these are the numbers of COVID reported cases in Massachusetts. And the red circles are these are active cases. The red circles are the kids under age 19 and younger. And then the other age groups, the 20 somethings are blue, and black are all the older adults. And you can see first, kids were had very low rates of COVID, or low recognition perhaps of COVID. And then over the next few months, the numbers really increased. Testing became more available. And you can see now, since the new year, since the winter holidays, the case rate is now, and in this younger age group, is the highest. And so all numbers are coming down, thankfully, in Massachusetts, but kids still remain the most prevalent group of COVID-19. And, fortunately, the younger kids have not seen the severe disease or the death rate that is really just heartbreaking in the older age groups. And so there's something to be learned here. And so there are clearly differences in illness across the lifespan. But what I want to reinforce is there are no differences in the safety precautions across the lifespan. And I'm going to sort of share my rationale as to why I say that. And really, it's this is the slide. This is why we all need to wear masks. We all need to social distance and wash our hands, regardless of what age you are, because there's no difference in the amount of virus across the ages. So here, this is on the left. These blue circles are amount of virus detected in the airway, detected through nose or throat swabs in kids across a range of ages. And I don't have this here, but the adult data is the exact same. So the age does not affect how much virus you could carry in your nose or in your respiratory tract. As opposed to, and what does change though is how many days into your illness you are. And so earlier on, either if you're asymptomatic or in the first couple days of illness, that's when you have the highest amount of virus in your respiratory, in your nose and in your mouth, and that decreases over the course of 2 weeks. And this exact same trend is seen in the adults. And what's not shown here, this is RNA that's detected, but live virus. This has not yet been published, but we have data to show that this is live virus as well. So there are no differences in what you see as far as how much virus you can carry in young kids, infants, toddlers, school-age teenagers, or adults. And so what does change though is the receptors in the airway. And the receptors are needed. Here on the left is a picture of the virus binding to this receptor in the airway or throughout the body. And the ACE2 receptor is one of the main receptors for the SARS-CoV-2 virus. And age has a big impact on how many of these receptors you have. And we looked at the amount of receptors in kids under age 10 and in kids over age 10. And you can see that there's a significant difference. So this P value is a marker of significance, and P less than 0.05 is considered significant. And this is much smaller than that. So it's a very noticeable difference. So younger kids have fewer viral receptors, and that probably partially explains why kids handle the virus so well. Their body, even though it's in their airways, their body isn't seeing it because it doesn't have anywhere to sort of attach to. Doesn't mean that they can't spread it necessarily to others, but their body isn't going to respond to it as much. And here's just an overview that I think at this point, a year into this, we all know this very well. So kids with COVID who are SARS-CoV-2, so positive for the virus as compared to kids who are negative for the virus and are just coming in for a sick visit, but not related to COVID, have very sort of mild symptoms, very typical of any cold. And so hard to tell who has COVID. There's no clear signal in kids who has COVID. There's no distinctive shortness of breath or something like that. It's very sneaky. You can't tell. And but how the body responds. So we said there aren't as many receptors, but there are some. And so kids do get infected, but not to the same degree. But when you do get infected, your body makes these antibodies. And so this is what the vaccination is built on. You were trying to build up this antibody response. But if you're not vaccinated, you need to make this antibody response on your own. And so one of the things we've been studying is how do kids make this antibody response as compared to adults? And just to sort of show you, this is a picture of the virus sort of sliced in half, and you can see different things that could trigger this antibody response. Any particle in the virus could, but the spike protein is one of the main aspects of the virus that triggers this antibody response. And here's a picture of the actual spike protein. And then here's a picture of an antibody. And all antibodies look like this. And then on the very end, there's this specific spot that binds to the part of the viral particle or the antigen, the viral particle. And that it binds to the viral particle and it shuts it down. It shuts, clears the viral particles so the virus can't infect you or cause any more illness. And this, again, the body generates these antibodies. The vaccine, generates your body to make these antibodies so that when your body encounters the virus, it quickly closes it down. And what we found, though, we wanted to see how kids and adults naturally make these antibodies if they're infected. And what you can see is, this is a lot of detail, and I'm not going through any of this detail, but I'm just looking at these color maps. And you can see, if you look here and compare it here without even knowing what these lines are, they look pretty similar. And so this is the antibody response for kids who have COVID. And most of them are mild, but some of them were hospitalized, but again, not to the same degree that some of the adults are hospitalized, and none of the kids died from COVID. And then here are adults with mild COVID. So the vast majority of adults who have COVID don't require hospitalization. And this is what their antibody response looks like. And qualitatively, you can see those are pretty similar. And then you look down at the adults who get sick and are hospitalized, and their antibody response is very different. It's sort of hyperinflammatory. And so there's clearly something going on there. I want to sort of take a sidestep and talk about what we've learned about vaccine and natural infection in pregnancy. And so this is with a collaboration with the OB COVID-19 Biorepository at Mass General, who I work the Pediatric Biorepository works very closely with the OB Biorepository. And we found that, so getting sick with COVID during pregnancy is not great. You want to avoid it because the mothers who are pregnant are at higher risk of severe outcomes from COVID. And so you want to avoid COVID when you're sick. Also, we're still learning about the long-term effect. If a mom has COVID during pregnancy, what the long-term effect is on the baby, but we can, have some sort of caution that other severe illnesses can cause problems later on. It can cause low birth weight, early birth. There can be some neurodevelopmental problems. So it's, again, we want to avoid COVID-19 if possible during pregnancy. And then the mom, if the mom is infected, will make antibodies similar as what I showed in the last slide. And some of those will get transferred to the baby. But what's interesting is not as high an amount of these antibodies get transferred as maybe, seen in other infections such as the flu. And so what that sort of tells us is there's maybe some protection that the moms are passing along to their babies, but not enough to fully protect the baby. So you have to still take precautions to protect the babies once they're born. Still have people around them, wear masks, social distance, that sort of thing. And so, and then what about vaccination during with the COVID-19 vaccine? And actually, a paper just came out in one of the major obstetric journals just today, in fact. And this shows that when you're vaccinated during pregnancy, you make really great antibody responses, better than if you got infected. And so that's wonderful. These antibodies will be passed along to the babies. Again, the babies still will need to be protected from getting illness themselves. It's not 100% of a guarantee that the babies are protected. But what you avoid is you avoid that high fever during pregnancy that puts both the mom and the baby at risk. So because of that, vaccine in pregnancy is considered safe, and it is recommended by the obstetric community. And so, so there's, like I said, there's that paper that just came out today, which is really exciting. So what about after COVID? So we all know now at this point that you have COVID early on, and then you clear it over the course of 2 weeks. You know, you have to do your you have to isolate, quarantine, and then once your symptoms are gone, you are considered non-infectious. But what's interesting is, although you might clear the virus from your nose, you still shed it in your stool for a long time, for weeks afterwards. And it's not clear that this is infectious. This is not, counting the amount of live virus. I don't think it's quite clear if the virus in the stool is infectious or not. I think most people think that it's not. You're just shedding the virus. But there is virus in the stool for a while. And I'm talking to individuals who know that gut health and what's going on in the gut has significant implications on the rest of the body. And we're learning that. And so having SARS-CoV-2, live or dead virus in the gut, it's, it has potential to cause problems. It disrupts the normal microbiome or the normal amount of bacteria in the gut. It can alter the immune responses that are sort of circulating throughout the body, and it can cause leaky gut, where the gut barriers aren't holding their barrier as much, and that can also cause inflammation and problems. And so in kids, one of the things that we've seen is after the early infection, so about a month later. This is rare. But there are now increasing number of cases, and I'll show it to the numbers in a second. But some kids can get this multi-system inflammatory syndrome in children, which I'm going to call MIS-C now because it's a bit of a mouthful. But some kids get MIS-C about a month after their COVID, and they might not have even had known they had COVID because the symptoms were so mild. But then a month later, they develop high fevers, and then they might have a rash. They often have some abdominal pain or GI symptoms of some sort, diarrhea, vomiting, and some of them have respiratory symptoms still. And sort of just showing you this linearly, you have the infection, many are asymptomatic or mildly symptomatic. Weeks go by, and then they develop MIS-C. And the cases have been climbing over time, and now we're up around 3,000. And so it was originally, it is still rare considering how many number of kids have COVID, but the more number of kids who have COVID, the more cases of MIS-C we will see. So the numbers will continue to climb. And there is a higher mortality with MIS-C than what we see with acute COVID in kids. And so this is life-threatening, and it is a very serious illness. And so a lot of people don't know that there's this potential risk. And what we've shown is, and this is not published data, but it's been submitted, so it hasn't yet been peer reviewed. So I'm sort of giving you all a sneak peek at what's coming. But these kids with MIS-C have markers of leaky gut, and this is what leaky gut looks like. So you have your, and I took this off of the web, and I took this off of a Celiac site actually. So this is something that I think many people in the celiac community know well. The gut epithelium the zonulin is released, and the zonulin sort of holds the gut cells together. and then they leak, and then you have this leaky gut where things can go from the gut into the bloodstream. And interestingly, what we've seen, you have virus in the gut. You have with Miss C. So kids have COVID a month ago. They have virus that goes to the gut. Some kids, for some reason, have zonulin release. So the virus in the gut is making the gut cells unhappy, and they release the zonulin, and the barriers loosen. And then parts of the virus can leak into the bloodstream. And when the virus leaks into the bloodstream, that causes this hyperinflammatory response where kids get very sick. They have high fevers. They can have cardiac complications, so it can cause their heart to not function as well, or cause bulging in the vessels around the heart, can cause liver problems, can cause kidney problems, neuro problems. So it's, it's a very severe illness. And so right now, all of the treatments, when kids come in with this, are targeting this hyperinflammatory response, so steroids, or we give antibodies to try to calm down the inflammatory response. And so what we have learned from the celiac community is that there are ways of targeting this zonulin release. And so we are looking into, and this is very early, but this is sort of what we're thinking is about using Lorazepide to prevent Miss C, or for treating it. And so this is a zonulin inhibitor that's currently in clinical trials for celiac disease. And there's a lot that celiac that we've learned over the time. This is a very safe medicine. It stays in the gut. It's an oral medicine. It stays in the gut. It doesn't get absorbed into the body. So it's very safe. It doesn't cause any side effects, but it could tighten up that gut barrier. So then the viral particles don't leak into the bloodstream, and the kids don't get sick. They don't get cardiac injury. They don't get the liver or kidney injury. And so this is very interesting. I want to just take a minute to say that, so this, we're learning a lot because of what we've learned from celiac disease. Lots of illnesses have increased zonulin for whatever reason, but those underlying illnesses, like individuals with celiac disease, are not at increased risk of developing this Miss C. And we don't know why. I think we have a lot to learn, but this is an early signal that there's something we need to investigate in this area. But certainly looking at all of the national and international data, individuals with celiac are not at increased risk of developing complications related to the gut aspect of having the virus in the gut. They're not at increased risk of developing COVID. They're not at increased risk of developing Miss C. They're not at decreased risk either, so we all have to take our safety precautions. But I just wanted to take a moment to say, just because we're learning and using some of the medicines that are being developed for celiac disease doesn't imply that celiac is a higher risk population. And so, what I want to say is that COVID-19 and Miss C are likely to be a lasting problem. And Dr. Levy alluded to this, that vaccination is going to have to really target this community, not target, but have sort of, build, be honest with what the data is showing, be open, engage this the kids and families, because in order to have a successfully overcome this pandemic, we know that kids are the most prevalent group of COVID, because again, they don't see the side effects, and they do pretty well, but they can pass the virus along to other individuals who will be more severely affected. And we don't know what the long-term implications for children are. We don't know that, there's a lot of early evidence that shows when kids are infected, even if they don't have many symptoms, they can have some changes that are in their lungs that are picked up on X-ray. And we know some of these kids then go on to have this Miss C, and what are the long-term complications of having these cardiac injury or the other things that can happen. So there's lots of long-term things we're obviously going to be looking very closely for. And so really we need prevention, we need vaccinations, and then we need effective treatments and other prevention options as well. And so again, I just want to reiterate Does celiac disease increase your risk of COVID or MIS-C? And the answer is no, it does not. Immune suppression, like inflammatory bowel disease or other diseases that require immune suppression with long-term steroids or things like that, can put you at increased risk of COVID because your body can't fight the infection as quickly when you first get infected. But celiac disease does not increase the risk of COVID or MIS-C, and this is based on very large epidemiologic studies that have been out. I combed through all of the literature to see what I could find, and celiac disease is not an increased risk. And so same with vaccination. So vaccination is safe and recommended in celiac disease, and COVID vaccination is also safe and recommended in pregnancy. And so I just wanted to underscore those. And then also, we'll learn a lot. Vaccine trials are being rolled out as we speak for kids under the ages of 16, I believe all the way down to 6 months now. And so we'll learn as those trials continue. But the hope is that we'll be able to vaccinate all of the population. So for now, while we await those sort of larger vaccine trials, the number one thing is wear a mask. And just as a reminder, the CDC recommendations are loosening for vaccinated adults. But I just want to remind people that children are still vulnerable to infection, and vaccinated individuals could still carry virus. So just be mindful of, when you do interact without a mask with other vaccinated individuals, who else is around? And don't forget that kids have not been vaccinated yet. And so they're still vulnerable. So wear your mask, wash your hands, social distance, vaccinate when eligible, and stay healthy. And with that, I just want to thank everyone for listening, and I'll pass it back over to Dr. Weir.
Thank you so much. That was excellent. So thank you to both of our speakers. We have a number of questions that have been rolling in during this webinar, and a number of questions that we got submitted ahead of time. So I think what I'm going to do is we have some celiac specific questions and some general vaccine related questions. And I think what I'm going to do is ask a few general vaccine questions and then go to some more specific celiac questions. So the first question is really related to FDA approval. And there was a question related to the difference between approval for emergency use versus full approval. And I was hoping that maybe Dr. Levy could talk a little bit more about that.
Thank you, Dr. Weir. And that's, of course, a critical question. That's a question that I had. I have served, well, a couple of things. First of all, I've spent the better part of my adult life studying infectious diseases, but nothing prepares you for actually living through a pandemic. That's a different kettle of fish altogether, isn't it? So let me just start with that. But I had served a 4-year term, I believe, as a permanent seated member of the Vaccines Related Biologic Products Advisory Committee, or VRBPAC, FDA. And we had always dealt with advising regarding approval and licensing of vaccines and other biologics. Now, in the context of a pandemic, we were sitting to convene to advise FDA, and I had finished my tour of service, but when the pandemic broke out, they asked me to come on board again as an ad hoc temporary voting member, or TVM, and they call me in when they need me. So, and I had to get up to speed and understand what is this whole authorization business. So I had a slide in my talk about it. It exists as a mechanism that's short of a full approval, exactly for these kind of emergencies, whether it's chemical, biological, nuclear, right, or some sort of infectious threat. And the authorization only lasts as long as there's a pandemic. So if we woke up tomorrow morning and somebody said, good news, coronavirus is gone, and there's dancing in the streets, it would no longer be legal to administer any of those vaccines. They're only authorized so long as there's a pandemic condition. So that's one legal and practical distinction. The other distinction is, these trials, the Moderna trial, the Pfizer trial, are 2 to 3 year studies. that are only several months in. So the studies are ongoing. So then you say, well, why are we approving this before the study's done? We're approving it before the study's done because we're in an emergency situation and greater than 500,000 Americans have died. And there was a median of approximately 2 months of follow-up in the study participants, whether placebo or vaccine, and rigorous collection of safety data. Now, if you look across the history of vaccinology in terms of vaccine side effects that are realistically associated with a vaccine and have been statistically proven to be associated with a vaccine, they usually occur within, days to weeks of receiving the vaccine. It's not, there are no established situations where you get the vaccine and then half a year later, suddenly you develop some side effect. So that's the rationale for authorizing before the study is over. But that's the long-winded answer to what the differences are between an authorization and an approval. And some of these vaccines may ultimately get approved as the studies finish up. If there's still need for coronavirus vaccines a year from now, which there may well be, they might eventually get converted to full approvals. But FDA would have to vote on that.
Thank you. Another question that we got in advance was, how long will immunity with the vaccine last? And will we need booster shots in the future?
So excellent question. We call that durability, right? Some vaccines protect you for a little bit of time, some for a longer bit of time, right? Yellow fever vaccine is a great vaccine. You get it and you're protected for 10 to 20 years after a single dose. So there's a lot of sophisticated science being done by us and colleagues around why is that the case, right? So why do some vaccines protect with a single shot for a long time and other vaccines protect you for a little bit and come right down? We don't know for sure because this is a new situation and we've only been following for months. It appears that Moderna, Pfizer, J&J, they'll protect you for 2, 3, 4 months quite well. Now, if something's providing you 80, 90% protection at 2 months, it's unlikely that at 2 months and 1 day, suddenly there's zero protection, right? We think this is antibody mediated. We know how long antibodies tend to last. So we suspect that we're on pretty firm ground for 4, 5, 6 months of protection. Where you are beyond that, it gets more and more murky the further along you try to project. So we don't know how it looks 9 to 12 months after the vaccine, how much protection you have. And then there are more and more variants being generated, right? So I don't know for sure, but it wouldn't surprise me. Now, I'm not speaking, all of my comments today are my own personal opinion. I'm not speaking in an official capacity for FDA, but it would not surprise me if there were booster doses or seasonal doses, sort of like you see with influenza vaccine. I think part of what we're seeing is the seasonality of the virus. The associate director of our program, Al Ozanov, his expertise are biostatistics and infectious disease surveillance. He told me from the very start, Ofer, you're going to see a peak in the winter. It's going to come down in the spring and summer. And then in the fall, you're going to see another peak again, even with the vaccines, hopefully not as large as the peak a year ago. And people are going to get nervous again. So there's the seasonality working in our favor this time of year. The vaccination is working in our favor. Some people have had, unfortunately, the infection, so they have some protection naturally. So that works in our favor. Those are 3 factors in our favor. Now we have some factors running against us. The variants, vaccine hesitancy, people's behavior. You're seeing the beaches in Miami filled with people on top of one another, right? So it's a battle between these factors, and we're going to see what happens. Yeah.
Great, thank you. Another question is, and I appreciate very much, Dr. Yonker, you clarifying and making it so clear about the risk of celiac disease in COVID infection and how people with celiac disease are not at higher risk of infection and that vaccines seem to be safe. But there were a lot of questions related to that. And a side question from that is, are people with celiac disease more at risk for unusual side effects after getting the vaccine?
So I have to, again, I had really looked through specifically for, after the vaccine, I have not heard of any side effects. And so, Dr. Weir, perhaps you even have more experience being a celiac clinician and can speak to that more directly.
Yes, I mean, the evidence right now, as we understand it, and as the Society for the Study of Celiac Disease has come out with a statement, we really encourage patients with celiac disease to get the COVID vaccine when it becomes available to them, and there is no evidence that there's increased adverse effect in patients with celiac disease in the vaccine.
And Dr. Weir, I would entirely endorse that statement. I sit on various committees, not just FDA, but also international vaccine safety committees that are looking at issues like allergy, clotting in Europe, et cetera, et cetera. I have not heard any chatter whatsoever of any increased safety risk in celiac disease.
Excellent. Another question that's an offshoot of that one is, will the mRNA vaccine make someone with celiac disease more susceptible to acquiring another autoimmune disease?
I am not aware of anything along those lines. There was a slight increase, but we don't know that it's statistically significant in some Bell's palsy in those receiving the mRNA vaccine. Very, very low risk. Very, very low risk. It's a weakness in the muscles on one side of the face, and it goes away. I mean, it's disturbing because you have a droop in your lip, but it goes away, and it's rare. That there was a little bit of a signal around that, not specific to celiac, just in general to people receiving mRNA vaccines. That's still being monitored. We don't know if it'll hold up under more scrutiny with bigger numbers. Thankfully, it's a condition that'll just go away, and you're at much greater risk of COVID, so please get the vaccine. Yeah.
And is there any specific vaccine that might be better or safer for somebody with pre-existing autoimmune disease of any kind?
We don't have a basis. It's a very logical question to ask. And as Americans, we like to have choices. That said, there is no basis to make a decision like that. None of these vaccines have been compared head to head. I know it's tempting to say, oh, well, this is the reported efficacy for this one, that's the reported. As we know, unless you compare them head to head in the same trial, with the same clinicians in the same populations, you don't really know how the three compare. Luckily, Pfizer, Moderna, J&J, we have three excellent, safe, and effective vaccines. Get them. And as I said on a recent interview on Fox Business News, it's the land of choice, but this is not like pushing your cart down the supermarket aisle and say, I don't like Cheerios, I'm going to get Trix. Grab the vaccine and get it. Most parts of the world don't have a vaccine. We're very fortunate here.
Another question that came up was, given the fact that some children with celiac disease do not become fully immune to hepatitis B after getting vaccinated, is there any concern that the same could be true for the COVID vaccine? And is there any role in patients with celiac disease, and I think I could extend this to patients in general, to have antibody levels checked at some point after vaccination?
Oh, thank you. That's an interesting question, but it would be a research question, really. And it's not generally recommended to check for antibodies. Obviously, that would not be practical to immunize, 270 million Americans and then check for antibodies. So that's not the route we're going. But as a research question, it might be an interesting one. Yeah.
This is a question for Dr. Yonker. We talked about celiac disease and risk of COVID infection. And some of our patients with celiac disease have other autoimmune diseases and specifically have type 1 diabetes. I know that type 2 diabetes is often flagged as a risk factor for COVID. What do you have to say about type 1 diabetes, and should patients with comorbid infection be prioritized for vaccine or have other concerns?
Yeah, I think that, as soon as you're eligible for the vaccine, and I think the eligibility criteria are rolling out at different paces in different states, but I would say you should get the vaccine. And so if you're at, if it puts you at increased risk or not, I think is, at this point, the question is, once you're eligible, you should get vaccinated. And I think that's going to be in short time, no matter what your risk factors are. If it's type 1 diabetes or type 2 diabetes, I would just say, it's at this point, just try to get your vaccine as soon as you can.
Thank you. Another question related to the vaccines is related to some of the discussion on social media and in other forums about reproductive complications and specifically infertility related concerns about the vaccination. Can you speak to that?
Yeah, I think that, as I mentioned, the risks to the mother, the risks to the fetus from being sick from COVID We know that being sick, having high fevers can cause issues with the pregnancy itself. It can cause preterm birth, or that can have its own sort of complications that go along with it, or long-term effects on the baby or child. And it also puts the mom at increased risk. The pregnant women are a prioritized group for vaccination. And so we know that COVID is hard on pregnant moms and on babies. I have not heard of, and Dr. Levy, maybe you know this literature better than I do, but I have not seen any literature about infertility following the vaccine. I think it's also very early to really look for that. But certainly there have not been any reports of any negative outcomes following vaccination either.
Yeah, I agree with everything you just said, Dr. Yonker.
Excellent, thank you. So here's a question. I think you made a convincing argument that children should be vaccinated when it becomes available. Do you have any estimates of when kids under the age of 16 will be approved for vaccination?
Thank you for that. And this is something that's near and dear to my heart as a pediatrician. There's a long history in this country of certain groups getting understudied. A long history of that. And whether it's women, whether it's children, whether it's people of color, there's a long history. And because pediatrics was so neglected for so long, Congress felt it necessary to pass the Pediatric Research Initiative. You look it up, the PRI, right, to direct federal agencies to include kids. And still, I find myself trying to remind people of this, that in a vaccine effort, where, the history of world immunization is a pediatric vaccine history. I mean, you go around the world, the only infrastructure you can depend on in Africa, Asia, to get vaccines into people is a pediatric infrastructure. And so this is becoming very important. The mRNA vaccine is a new technology. We need safety. Vaccines you give to healthy people, there'll be dose ranging. You can't assume the same dose in kids. Those studies are ongoing. Pfizer, Moderna, different ages. I think now Moderna is going down as low as 6 months. These are just headlines I'm seeing. I don't have any inside information, but that'll be really interesting to see what that looks like. And we need the safety and the efficacy data. And then J&J is in an interesting position because they have this adenovirus vector. That's actually been in kids before. That's been approved and used for Ebola. And has been in kids as low as 1 year of age in Africa to prevent Ebola. So there's a large pediatric safety database for that technology, and they're going to be going for it as well. Remember, the Pfizer goes down to 16 years of age. That was a battle. I fought that battle. I don't know for any of you who watched the live stream on the Pfizer. There were committee members and some who wanted to say, no, we'll just make it 18 and up. There weren't that many 16 and 17-year-olds in the trial. They don't get as sick. What's the rush? But I hung in there, and I think Eric Rubin did as well, who was on the committee with me, editor-in-chief of the New England Journal, and eventually we got the vote on that 17-4, and now 16 and 17-year-olds can get the Pfizer vaccine. But we'll see. I think we're hoping that by end May or so we'll have a robust supply, and the 16-year-olds can get their Pfizer vaccine. And that by the time the school year rolls around, we'll have the vaccines for the teenagers, hopefully. For younger infants and such, we still may be a half a year or 9 months away. It might not be till 2022. But we should be able, and here's the mixed message, the nuance, we should be able to open the schools sooner. And I think, yes, of course, the elderly teachers, the teachers with comorbid conditions need to be protected, need to be immunized, the social distancing. But the kids, although it's favorable to get them immunized, don't need to be immunized to attend school. There's safe ways to do it. CDC has the guidance. In my opinion, we overclosed the schools. It got mixed with politics, unfortunately, in an election year. And this is really a generation of children that suffered tremendously from that. We need to get them back to school and activities.
Thank you.
And if I could add to that, I think that we've learned, the schools are excellent about enforcing rules and enforcing masks, and so I think that has really been the high numbers that we see in kids are not coming from the schools, because in the schools they are following all of the safety precautions, because people are aware, teachers are aware, and the administration is aware, and highly motivated to keep it a safe place. And so I don't think that those numbers are being driven by schools.
Another question, which is more of a general vaccination question. Should you still get vaccination if you've had COVID-19? And if so, will you respond differently to the vaccine?
Yeah, so the answer is yes, you should get it. And because the protection from the vaccine exceeds that from natural infection usually. And you would respond differently. You might have a super response, which will, in a good way, you may be protected for longer. So go for it. It's really very good for you. Because remember, a natural infection provides some protection, but the durability is a question mark. The protection against variants is a question mark. The vaccine is added value. Go get it.
Excellent. This is a specific question regarding people with multiple food allergies, specifically anaphylactic food allergies. Should a person, and a child specifically, when the vaccine becomes available, get vaccinated in a hospital setting if they have multiple food allergies?
Thank you for this. So the guidance on allergy is that as long as your allergy is, if you had an allergic reaction to one of the coronavirus vaccines, then you probably shouldn't be getting it again unless you're under the treatment of an allergist to do a graded challenge or something unusual like that. If you're just an individual with a background allergy history, vaccines, they're not giving you the vaccine on the street or in your house, right? They're giving you the vaccine in a clinic, and you should probably be observed, whether it's 20, 30, or 40 minutes, observe you, make sure you didn't have a reaction. If you did, they can treat that reaction, so just stay calm, and you'll do fine. My parents live in Israel, and it was amazing. The vaccine rollout there, over 50% are immunized. They went by car. They didn't get out of their car. You roll down the window, you show your national health ID card, they scan it, you roll up your sleeve, you get a shot in the arm, and then you drive to the parking lot to wait for 15 minutes, make sure you didn't have a reaction, and you drive home. Didn't even get out of their car. They have over 50% of the population already immunized. So there's really some great example there on how to do this and how to take that allergy thing into account. I think the world is rediscovering the value of vaccines, right? I mean, people used to be afraid in this country to send their kids to swim in the swimming pool in the summer. They're going to get polio. When was the last time any of us worried about polio? When was the last time we had to worry about measles? Smallpox. Who worries about that anymore? It used to kill millions of people. Vaccines are a victim of their own success, and the world is relearning what a vaccine can mean. Now that elderly people can sit together and have dinner together and talk to each other without a mask because they were immunized. I mean, just that basic human concept. So please get immunized, tell your family and friends.
Excellent. Thank you. The last question before we wrap this up is, do you have any recommendations about the best source of information on vaccines going forward?
I would look at the CDC, the Centers for Disease Control. They have a lot of great information on their website. I know some of the people on the Committee on Immunization Practices, ACIP, including Grace Lee, who trained here as a fellow, now is at Stanford. Great committees there putting out a lot of good information on the CDC website.
Wonderful. Thank you guys both so much.
Thank you. Bye-bye.
Thank you.
Pass it back over to Lee.
Hi, everyone. Thank you so much. This has been great. COVID has really changed our lives in so many ways, and I hope everyone found today's speakers and their information helpful. Certainly I did. It was wonderful. As we mentioned before, a recording of today's webinar will be on the National Celiac Association's website, probably in the next week or so. Meanwhile, please join us for the next webinar, Thursday, April 15th at 1 o'clock Eastern Standard Time. It's going to be gluten-free, farm to table, delicious, nutritious, and affordable options for real food. I can't wait for that one. Meanwhile, stay well, and we'll see you next month. Goodbye.